All right. Hi, everybody, and thank you for joining this core sponsored presentation on hot topics in substance use prescribing, but particularly long-term opiate treatment. Once again, if I haven't met you over Teams, I am Dr. Courtney Phillips, board certified in addiction medicine and general psychiatry, and the director of opiate recovery for DCF with the CORE project. And I'm very excited to be here. I wanted to first state that I'm so proud of what everyone's doing on this call and the efforts going into every county. But I also wanted to sort of talk about what is this lecture geared towards. So this is geared towards all those difficult things that are difficult to talk about that make treating opiate use disorders difficult for the people on the ground treating it. A lot of these scenarios we're going to talk about come from my own experience as a direct provider for many years in public health clinics that are integrated with opiate use care. And I really welcome participation from the audience. So thank you for being here. If you're an administrator, this might be helpful. It also may be somewhat clinical, but it's still good to understand, because this is, if you're an administrator, this is what your nurses and doctors and social workers and support staff who are taking care of these patients may find difficult. And everyone can see the screen, right? I just want to make sure.
Yes.
You're seeing PowerPoints. Okay. So if any of you guys used to watch The View or still do, I think they have a segment called Hot Topics where they go over things that are a little bit controversial in treatment. And of my years practicing this for a decade, as well as talking to different teams and the problems that they face, and probably some of the biggest reasons for burnout in this field, those are the things we're going to go over today. We're going to go there. So this is very interactive. So I'd like you guys not to worry about raising your hands. I just want, you can raise your hand, and I would like Shannon, if you don't mind, calling those hand raisings, because throughout each slide, I would like you to interrupt me if you have something to say or something to add. Topics are based on experience providers have had and questions that have arisen throughout the years. Let's talk about the problem that we're facing. Providing effective substance use care is highly rewarding, and anyone on this call has a passion, including me, and an empathy for substance use disorders as a disease that needs really good treatment. The other thing I want to make clear from the beginning, patients do get better. They really do. But the disease itself affects judgment and insight in the brain, and this affects their behavior. This can be difficult sometimes when you're actually taking care of the patient, and the teams sometimes struggle to show empathy while also setting limits and when to do what and what is most helpful for that patient. Just like families who are dealing with a loved one with a substance use disorder, treatment teams can actually either enable or be overly harsh, and it's a very fine balance. A small subset of patients can cause a lot of disruption in a clinic and need a concerted effort by the team and constant communication. So, like I said, I want to start this lecture by saying the majority of patients are here to get help. They want help. They're engaged. They do get better. And I love this job because I get to see that progress, not just in their substance use, but they start to thrive in their life, and they start to, really engage in the community and become independent again. But there is a small subset that at times, if I'm not being honest with myself, I scratch my head and I go, why am I doing this? This is so frustrating. And it also invokes a lot of things within us when we treat these patients. So these patients know how to push our own buttons. And if you're not honest about your own button pushing and what gets you going, it's going to be hard to do this long term. You really have to be honest about the things that you struggle with in treatment. So this is not about being proud or strong. All of us have biases. All of us also have types of patients we struggle with and types of interactions that we struggle with because we are also humans with our own set of psychology and social circumstances and moods. um, Teams caring for these patients, and this is probably something, this is not a core element, but something I'd highly recommend, that teams really get into the groove of processing difficult cases. um, First of all, it's just good to get validated by your team if you're saying, gosh, I'm really struggling with this patient. It also allows you to get it out with somebody other than the patient. And I always say this to my teams, we need to treat every patient the same, whether we like them, we don't like them, or we're in the middle about them. We do have to be honest about how we feel about the patient because we don't want that to subconsciously play into how we interact with them. But just because you really like a patient doesn't mean you shouldn't give them favoritism. And just because you don't like a patient should mean that you're always putting them in sort of a punishment mode subconsciously. So there's a lot of checking of yourself. If you have a healthy team dynamic, your team will check you too. So it involves really pouring yourself into this work. And also the team can help you come up with a behavioral plan to provide structure that also helps the patient. Sometimes helping the patient is you know, being kind and empathetic and listening. Sometimes limits do help patients because they live in a real world where you can't do infinitely whatever you want. So this is the part where psychiatry, psychology meets the medication assisted treatment that's needed to keep these people alive, but also to help them to start to thrive. And the team can make a huge impact on the patients if they work together and they don't sort of silo themselves. The other reason for this team approach is that you don't get burned out. Sometimes in treatment team meeting, it's healthy to laugh. It's healthy to get it out there. Like I said, this is very intense work for the people doing it. And I want to start the conversation. We're going to be talking about the more challenging cases, but I want to make sure that anyone watching who hasn't been at my other lectures knows people get better. I believe that. I wouldn't do this if it wasn't. And I try to check myself as a provider so that I can continue to show up to work every single day and take care of every single one of these patients who deserves really good care. And really good care means processing the difficult patients. I bring this up one more time. Many of you have seen this. This is a representation of brief addiction monitors in my in my program that I helped run in Palm Beach County and continue to help with. Um, and again, I want to mention that regardless whether the patient readmitted, a lot of these patients that are in these um, in this survey on the individual level, they have readmitted to the program 15, 16 times. But the more BAMs they complete, meaning the more times they show up, whether they're doing well or not doing well, or they're sober, or they're using something, or they're reducing, over time, you can see their use decreases, their risk decreases, and the amount of support or protection that they have against their substance use starts to increase. So keep in the back of your minds while we're going through this lecture that the more they come, no matter what state they come in, the better they're going to do by the data. Okay. I do want to mention too, something we've been following, and I've showed this before. We started to isolate because we were having in our program in Palm Beach challenges with losing patients between 4 to 6 weeks. What we found is if they were just isolated opioid patients, we had a very high retention rate. But when we isolated patients who either had unstable housing or homeless or alcoholism, along with their opiate use disorder, our retention rates dropped significantly. Why am I saying this? I'm saying this, there are factors that are also challenging along with opioid treatment. And this is just two. There's many more. When we talk about opiate use disorders, we're not just talking about drugs in the brain. We're talking about legal issues, psychosocial issues, transportation barriers, homelessness, family issues, interpersonal issues, difficulties with work and money. So these patients do come with a lot of other things when they come to get help for opiate use disorder care. So I wanted to start this discussion, making sure that anyone who's new to us knows that this isn't just a simplistic, um, thing that we can treat with a drug and it's over. This requires long-term treatment and complex treatment with lots of creativity in terms of using all the resources out there. So I also want to remind you, I've gone over this at a lot of different lectures, but this is our phases in our outpatient opioid treatment program in Palm Beach County. People start with 1 week of medications, then go to 2, 3, 4 weeks. You can see the criteria there. I'm not spending this time to go over that, but I wanted to make sure that this is in the back of your mind as we're discussing things. Because as difficult as patients struggle, we tend to keep them on lower phases when they're struggling so that they get more support from the clinic while they're using, getting the medication. And if they're doing well, they get to escalate as they're showing us to 4 weeks that they can handle being away from the clinic and all the other things that are going on. I can tell you from our internal data and anecdotally from treating these patients in this clinic setting for years, people who are at the higher phases tend to also have a phone, a job, housing. So as they phase up and they get more stable with their substance use, they also tend to be able to thrive in life goals, such as getting more responsibility, launching, if you will, into adulthood, because a lot of them are stunted during use, excuse me. So, and then at the lower phases, we still deal with a lot of the psychosocial issues. So as they keep coming in, we address different things at different visits. So I want this in the back of your mind. And before we get into the scenarios, a lot of these solutions are not in the literature, but can be informed by evidence-based treatment. So motivational interviewing, harm reduction, contingency management, they can inform our approach to difficult scenarios. So it's still good to know the literature, but it doesn't mean that there's an answer in the literature for absolutely every detailed issue. So you have to really understand the concepts so that you can approach it with that mindset. Clinical experience is meant to be shared amongst all of us with treating principles in mind. So also ethical principles, causing no harm, non-maleficence, benevolence, justice, autonomy. Anyone who's a doctor on this call or a nurse, you learned a lot of this in your training, but you really do want to approach patients with a do no harm, do good, and respect justice and autonomy. And I want you guys during this lecture to speak up and share your thoughts. I really don't want to be a talking head. This is, like I said at the beginning, when you saw the hot topics of the view, this is a discussion table. So I'm bringing hot topics that I've gone through with my team for years and ways that we've addressed them, but I also want to hear how you're doing it. Remember that part of the value in CORE is that we're sharing ideas and making each other better and stronger. So please speak up. And to those providers new to treatment, no matter how hard providing care is, it is so rewarding. So please keep in mind that we're talking about tough stuff this session, but it is overall rewarding. These are the ones that need to be discussed. And I do want to mention that I've worked in primary care clinics. Primary care has the same difficult patient issues and they come with a different flavor. So probably treatment teams should discuss things in every clinic. Suboxone maintenance can be the carrot or the motivator to keep engaging with the care team so that over time they learn from the care team how to have healthy boundaries. A lot of these patients, just to be very blunt, have burned bridges with most of their social contacts when they show up, both in the community, their families, and friends. For a short time, they bond with the treatment team as a sense of family or community. And a lot of these patients grew up in situations where maybe there weren't healthy boundaries in their life, ever. So this is a foreign concept to them, and they're getting introduced through substance use care. So it's very important that the treatment team exercises the unconditionality of what it means to respect a human. So to show that person unconditional support while also setting limits, because limits are important to contain all of our impulses. And the world doesn't work without limits. If you're going to work at a job or you're going to thrive in society, you have to understand the balance between kindness and limits, and that limits in a kind way can be kind. And for some, we've had in my clinic, we do a group every holiday where we feed the patients. Everyone donates and we get them a meal because most of them don't have a family to go back to because they burned a lot of bridges. So for a while, when they're really not well, we become their big support, and they really model, they're going to model their new life after what the team, how the team responds to them too. So I'm going to ask you guys to think of scenarios as we go through this that you've encountered that are difficult, how you've dealt with them. But I also want to ask the team meaning the core family here, what would you define as a healthy support? Anybody?
A healthy support is someone who kind of has the person's recovery in mind and is there for them through the negatives and the positives, and just making sure that these various support systems in place, like if they could be formal, informal, are just really there to support the participant through the highs and lows
Right.
of recovery.
Excellent. Thank you so much for saying that. Anybody else?
And breaking it down to the street level, where I know this is kind of all starting now, from where it has been clinical in the past, what we see as healthy support is being in a house that somebody else isn't using with you, or the people that are using that are in that house are willing to start the program with them.
Okay, excellent. Does a healthy support, even though, and I like what you guys are saying, how they're always there for you. So the clinic team is always there for you, but does a healthy support always say yes to you?
No. Yeah,
Okay.
no. I think that's one of the parts of being a healthy support, is knowing when to say no, especially if it's the best interest of the participant.
Right. And so this is very important. Sometimes as a team, a treatment team, members of the team say, well, I'm just here doing my job. You guys really are modeling, as you interact with each other and with the patients, a consistent example of healthy supports. So it's very important that we think about this concept, and I appreciate the participants. Anybody else want to add anything? Okay. So I just want to assume, because I want to gear this towards what most core counties are dealing with, which I have dealt with for years in Palm Beach County. For the sake of this discussion, let's just say that inpatient beds either aren't readily available for the moment, or the patient is not willing to accept inpatient services at the moment. So I wanted to do that because in reality, there's always going to be a resource limitation with beds. Now, all of us, including Palm Beach County, should have hopefully detox and inpatient beds. That was a core component to have in your county, but there's never going to be enough to put everybody in it. And there's never going to, every patient isn't going to come saying, thanks for the recommendation, I'm definitely going to do it, right? So I want to have these discussions as if you have to keep this patient in the clinic for either resource reasons or they're not motivated, because obviously it's always wonderful when there's a bed, they're homeless and they want to go, right? So, but doing this for a long time in public health, that's not often the case. If it was, we probably would be a lot further along, because previous approaches to substance use care were very heavy on inpatient. Okay, so the first scenario that I'm bringing up. Oops. Okay, so the patient who keeps getting Suboxone or buprenorphine in the ED or EMS system and then never shows up to long-term treatment for maintenance. All right, anyone in the audience dealt with this? Go ahead and raise your hand in your chat, or say something in the chat. All right, yeah, I see multiple hands going up. Does anyone want to talk about a specific scenario they've come across with this?
Hi, it's Carmen.
Oh,
Hey, Carmen.
This is of a personal nature. I have a stepdaughter that is suffering substance use disorder, has started treatment multiple times, has not followed through, and each time she starts, she appears to be motivated, but then falls right back into those same habits. So it's frustrating for us as her family.
Yep.
But each time that she does decide to go back and seek some type of treatment, we're cheerleaders and her support system, and just hoping that this is the one time that she'll actually stick with a program. And I'll also speak to the fact that there was a time that she was more motivated than others, and that probably had to do with the fact that DCF is involved and have
Right.
removed her child, but there was no bed.
Correct.
So, and that was her reason for going back into the old habits was, well, there was no place for me when I was mentally ready.
Very good point. So she wanted a bed, but remember, we're setting up core programs to be a clinic that can at least do a lot for them in the clinic, if, you know, so that there's not this all or nothing concept with beds. And for the record, you know, rehab does help people, but it's not always available in this setting. So thank you for sharing, Carmen. So what, from a family standpoint, obviously your family member obviously is an example of this, and thank you for sharing. How does it feel as a family member to see this happen over and over again?
Um, it's deflating.
Yeah.
We keep thinking, what else could we do? What else could we say? We've gone the gamut where, and I'm going to be fully transparent, where we're like, you should be ashamed that your child has been removed from the home. If your child is the person that you love the most in the world, but you're not willing to stay clean for your child, that didn't work. She lived in her car for 2 weeks, and we offered her a room in our home, but here were the rules, and she went by the rules for 2 days and then slid back into that same behavior. So she was no longer allowed to stay in our home because we also felt that we needed to protect ourselves, despite how your heart is breaking because this is someone that you care about.
Absolutely. And it's so intense on the family side. And I hope that she's able to find the motivation that helps her, but that can be very frustrating. Sounds like you guys are really have a healthy balance of pushing and having some acceptance with where she's at right now. But
And and I will share that we have also had to tell other family members not to be an enabler,
got it.
because we were viewed as the bad people because we put her out. No, she didn't abide by the rules of the home.
Got it.
So we couldn't expose ourselves to that.
So this is a very good example, and this happens a lot in ER and EMS, and I appreciate. Thank you so much, Carmen. Is there any EMS representatives who pick up patients constantly in crisis and try to motivate them to get to a longer term treatment plan, like in a clinic? Okay. I know in our local EMS, there's multiple pickups sometimes for the same person over and over again. And this, a lot of times the team's reaction is, oh my gosh, it's this person again. Why is this patient so frustrating? Because they keep coming, they keep utilizing services, and emergency rooms are not necessarily used to long-term care. Even though emergency rooms have become a receptacle for people who have nowhere else to go, when there is long-term care and the patient is refusing, how can you think about this? So first of all, motivational interviewing in action is first. What Carmen said, it sounds like her family, but the treatment team can always continue to engage them. If they keep coming, if you can find it in yourself, be like, I'm so glad you're here again. I'm so glad you came back to us again. Okay. What made you come back? What made you not follow in the clinic the last time we saw you? How did that go? How did that not go? These are the tenets of motivational interviewing. Motivational interviewing is not you telling the person, obviously, to what you're saying, Carmen, sometimes even legal and DCF involvement isn't enough, or homelessness. I've been humbled when I was a young doctor many years ago. I used to think, well, everyone wants to get off the streets, and I've learned that sometimes people do, and many times people do. Sometimes people say, I don't really want the expectations on me that comes with having housing. And they get pretty used to being out on the streets after a few years, and they start to really adapt. So you can't always say, well, you'll be on the streets. That might not be a motivator for that person. So more so saying engagement, what are your goals? Really re-asking them. Maybe they keep coming to the ER because, yeah, they like to get Suboxone. That's fine. But what they really want is medical treatment. So how about instead of talking about Suboxone maintenance, say, well, the clinic that would continue this can be your medical provider, or the clinic that can continue this can help you with those sleep issues you keep coming in with. And you can go there all the time and get help with your sleep or your whatever psychiatric issue is going on. So trying to see if there's a treatment element to the program. This is why it's important that these clinics have comprehensive services. We have some patients who come in and say, listen, I'm going to do MAT, but I really want Hep C treatment. That's their main focus. And they get that treated. And we hope that by the time that's treated, they're starting to sort of change in terms of their judgment of the situation as things clean out. You also have to accept the significance of ambivalence. And it's very hard when it's a loved one because you love that person and you're scared and they can actually die. But people do have a right to make choices, bad or good, in this country. And there's some acceptance if you've really tried to deal with that ambivalence. What can be done about it? The best thing you can do in an emergency setting is to try to check your reaction of, oh my God, they're here again. Try to avoid the eye roll. Say to your colleague, I can't believe so-and-so's here again. But when you're with the patient, say, I'm so glad you came back. It's good to see you. What made you come this time? You left last time. Let's talk, see if you can have that moment to analyze if they're willing to learn from that relapse. And if any new motivation has come into play. And, obviously in the ER, you have limits on how much you can prescribe. You can tell the patient, I know some of the ERs will give 1 day, some of the ERs give 3 days, some give up to 7. Know your limit and say, hey, Mr. Jones, I know that you come in here and you want to do this over and over again. I'm limited. I can give you up to 3 to 7 days, and I will. But you have a place you can go and get this consistently. What would it take for us to help you get there? This is also where a peer specialist in the ER can be very, very helpful. They build a relationship. So if the patient comes in 6 times and they see that peer specialist 6 times, they start to become friends with them. And maybe that peer specialist talks to them outside of the emergency room and goes to where they live in their car and meets up with them. And this is why having peers is so, so important, and also a support for the team. So I want to bring you back to motivational interviewing. If you're frustrated and you feel like you're spinning your wheels, it's okay. It's going to take multiple times. And we're going to go back to that graph. The more times they present, oops, I'm going the wrong way. Sorry, team. Let's see. The more times they present, more likely they're going to get better. And getting better doesn't always mean complete sobriety. It often means kind of partial sobriety, harm reduction, and maybe getting some of their other needs met. Any other thoughts or questions about this scenario that happens very often?
Dr. Phillips, it's Carmen again. I'd like to ask or share. We had one woman in our county that EMS had to show up for 3 separate times throughout that day, and she just wanted them to stop showing up. And how do you still try to help someone who doesn't want you to stop showing up for my overdoses? Just
Well, I'll say what I'd say, and I'd like to ask the teams on the call what you would say. I would say to this patient, I hear that you don't want us here, but when somebody calls 911, we have to show up. That's sort of the line. Like when this phone call is made, we will show up. Now, after that, it is up to you, but we're going to show up every time the EMS is activated. I'm sorry if that's not what you want, but that is how the system works. After, you wake up and you're engaged, we might be able to discuss what you really want and respect your autonomy in that way. Okay. And the other thing I'll say about that, this is where having those pre-hospital buprenorphine inductions can be quite helpful. because you can do them within 2 hours of Narcaning someone, and they can feel better immediately, often when the brain is settled down in terms of withdrawal, because Narcan really activates them. The conversation is completely different. I frequently see people on their first day, and a week later, if they stick with us, they're a completely different person because they don't have that craving withdrawal cycle driving them to continuously leave. So that's a very good question. Anybody else on EMS?
Hey, it's Glenn. One of the big things, I know we have participating hospitals and non-participating, but one of the things that we found was you've got to change the mentality of your ERs to get away from catch and release. The reason why that woman overdosed 3 times in a day was because she went to the ER, they cleared her, they let her go, and she was probably never offered anything in the hospital. But we also have to aggressively offer it in the hospital with the peers and the staff, and everybody's got to be on board for it to work.
Yes. Glenn, I'm glad you mentioned the system. So when the system's in place, how we would like it to be with CORE, where ERs are really trying. Now, ERs, even in Palm Beach County, where we've worked with ER for years and they're very comfortable with these patients, sometimes the patient still wants to leave, but they've talked to a peer, they've talked to the ER staff, they've been consented, and the automatic response isn't to let them go, which is, I think, what you're saying. There has been a trial to try to engage that patient over different services. So that's a very good point. So that's why it's important to have EMS and ER and the clinic all working as an ecosystem for this patient, so that the mentality is, let's keep them here. And frankly, like in my clinic, you know, I'm just gonna say this, we have a coffee machine. Sometimes it's a cup of coffee that keeps somebody there. Okay, it's the simple humanistic things. When we had a chance to design a clinic just for us, which just happened, we made what we call a patient lounge. It's a room that's comfortable with a couch where we can say, well, you know, you're not sure what to do. Why don't you hang out in here for a bit? And just getting off the streets and being in a room that's feels like a home, and a cup of coffee, you'd be amazed how that helps, that kindness, that simple gesture. So it doesn't always have to be some, you know, completely crazy medical interaction. It's a human reaction. And if they get that repeatedly, it does make a difference. Even if all they do is start engaging in medical care or OB care or psychiatric care, maybe they start with those specialty services and they don't even want to do MAT, but they like the way they're being treated. And I can tell that the people who come back typically don't come back because they were treated poorly. Okay. Unless there's anything else, we'll move to scenario 2. Thank you guys so much. Very good discussion. All right. So second scenario, the patient who shows up at the clinic with no appointment in the last 30 minutes out of Suboxone and misses appointments. So let's just say that the clinic closes every day at 5. Let's make a guess. And the patient, they have an appointment scheduled regularly that they miss, and they show up every day at 4:54. This really has happened to me multiple times, multiple times. Has this happened to anyone else? Well, if you have a clinic that's taking these patients, it will. What does it feel like to staff? So what it feels like to staff is the staff is there all day, working hard, seeing lots of patients. It's 4:54. Staff are people too. They want to go home. And it's the same group of patients, the 5 patients, they show up late in the day, and everybody ends up staying till 6:30 when there are no limits around this. And that creates staff burning out, then staff quitting, and then lots of difficulties maintaining staff. Because ultimately too, if you work in this system, you have to go home and you have to, you know, do your own self-care, which occurs after your shift or your day is done. Now, with that being said, I've always stayed for real emergencies. If there's I'm a physician, so someone's in cardiac, having a cardiac event, or it's a Baker Act, I just have to stay. That's my duty. But this is a patient who had no other reason. They just keep showing up late. A lot of times what I found in dealing with patients like this, there's a couple things. When a lot of patients start off in treatment, let's say a patient has been using from the age of 20 to 35, and they really get serious about treatment at 36. during those 15 years of continuous use, they've lost a lot of psychological development. Okay. I want to ask the audience, what kind of developmental things do you learn in your 20s and 30s? If you're not using substances, what kind of things do you experience that help you grow into the wise middle-aged person that you become?
Getting married,
Yeah,
parenthood.
parenthood. You have a breakup, right? Disappointment. You lose a job. The world
Money
is.
management.
Yep. Anyone out there? Go ahead.
Graduating from college or falling out of college.
Right? So if any of you guys have young adults, you're watching your, previous teenagers turn into adults by having these life experiences, good ones and sometimes not so good ones, and helping them manage it. And that is how you grow. When you've been using drugs for 15 years in your 20s and 30s, what happens to your brain? You're numbing all feelings around those experiences, correct?
Yes.
So they don't develop. They're not always developed. So sometimes I have a 38-year-old who's psychologically more like a 21-year-old because they haven't ever really experienced that. So they'll get anxious. They'll say, I had to wait in traffic. Now, most 38-year-olds or 40-year-olds are saying, yeah, traffic happens. It's part of life. But for this person, they've never been conscious or in a state of mind to really appreciate what's going on with traffic. The psychological part of use is that I feel something, I take something, I numb out, I check out. So it deprives them of opportunities to learn. So a lot of the patients do this behavior. Like I said, they show up in the last 3 minutes of clinic. They say, well, I'm here, and if you don't give me my Suboxone, I could go into withdrawal and die. And I know you don't want that, Dr. Phillips. I mean, sometimes it's even a bit manipulative. They are correct. These clinics should not be set up to not give them their medication because we're losing kids left and right, and the evidence doesn't support it. But how do you do that and still have them respect some structure in the clinic? Any ideas?
Is it possible to have an after-hours staff
Well, that's the emergency
for a
room.
certain day?
That's that's a very good point. So you could have late hours, but even if your clinic, I guarantee you, even if your clinic closes at 9, there will be 4 or 5 patients that start showing up at 8:45. It happens we changed our hours multiple times. We had a 7 o'clock night, a 6 o'clock. There's always a group of patients that pushes it right to the end. Now, we have an emergency room right across the parking lot from us who will help with our patients, but we don't want to abuse that. That should be truly for people emergently. So as a clinic, we want to support our ER team and not just quote unquote dump the patient over there. It's also very costly to the system to keep doing that. So that's a very good thought, is to have some, just to accommodate maybe a couple late nights. But even on those late nights, what would you do if a patient kept showing up, missing their appointment, showing up after, real close to the end of the day?
I know part of our protocol is that we share certain aspects as far as like the clinical team, they rotate out to make sure not one of them's constantly having to stay. The provider does hold the patients accountable for it to a certain point, because that's part of like their agreement with us under treatment, that they're staying within and following certain guidelines and rules, and kind of holds them to that for accountability. Of course, every situation is patient case by case, but that seems to be working a little bit more to where we're only having a handful of patients doing that.
Okay, great. Well, let's talk about why someone would be late. First of all, we talked about this failure to launch. Some people are struggling with schedule, transportation, right?
Yeah.
We want our care coordinator to start saying, what's making it so hard? Because I know in Palm Beach, our bus system is very, very, very slow, and the buses don't always come on time. And I know some of your counties don't even have a lot of public transportation. So that's one thing to consider. But also, a lot of these patients are getting in their first job in 5 years. What happens if you keep showing up 4 hours late to your job?
Fired.
Yes. And that's new for them. So by modeling, good. So what we do in our clinic, if we close at whatever time we close, patients, so if we have a patient scheduled at 10, we do have a lot of walk-in slots throughout the day. So if they show up by 1, we usually can handle it. But number one, the patient stays on phase 1. They stay at 1 week, because getting here on time is part of the program. Especially as we also are helping them with transportation and solutions. But the patients know that if they're coming the last 45 minutes of the day, they will get medications every single time. I never tell them they're not going to be on meds, but they get 1 day's worth. 1 day. Or 2 days, today and tomorrow. And we say, well, we're glad you came. So glad you're here. I'm sorry we had struggled. Let's figure out what to do. But we need to really sit down and figure this out. And we're kind of out of time today. Our clinic closes in a few minutes. So what we're going to do is give you 2 days off of a nursing visit. And then we reschedule them for the next day. And I have had patients who've done this 4 days in a row. But almost all of them eventually start coming on time. So when they start coming on time, or, in a more reasonable hour of the day, they get phased up. And many of them, once they start coming on time, they're able to maintain jobs. They're, this is what's happening to us is happening to them at every appointment and every interview. So these are things, it's tying the harm reduction of never taking away their meds, but also a behavioral approach to help them launch and say, hey, you got to keep a schedule. You got to get here. Let's figure, we have lots of, in my county, we're lucky we have a lot of transportation grants. So we use all of those to help the patient get to the appointments. And then I know some of you guys are using Tele as an option as well. So, but I'm being honest with you, a lot of my new patients don't even have a cell phone. So Tele is even a limitation from a psychosocial standpoint. We have more success with our homeless patients without cell phones coming in than doing anything Tele. So, but I know all the counties are different. I know the rural counties are very different too. So that's what we do. That's what we've developed, and it's worked really well because my team feels supported. I have people at the front desk. They need to get their kids from daycare. Once in a while, all of my team will stay late for an emergency, but we can't expect them to do that every day and come in every day and do this work and feel balanced. It creates burnout. And if you can't staff these clinics, they don't run. So it's very important to support the patients, and also, and we never are harsh with them. They may act up, and I say, yeah, man, it's too bad that when you're late, this happens, but this is what happens. And you know that. I will be giving you the 2 days, and I'm so glad you came anyway. Let's figure out how we can stop this pattern, okay? So you can say it with an empathetic response. Anybody else have, and I can tell you if it's never addressed, the other thing that I've had experience with in Palm Beach County is the using community talks to each other. So once your clinic gets a reputation, or your ER, they're going to say, well, go here or do this. This is what they'll do. My first year out as a very green provider, I didn't have these limits, and I was staying till 2 hours past the clinic day every day, and trying to make everyone happy. But I myself was burning out, and I said, I can't do this for long term if I don't, the shift, the day has to end. So yes, you can make accommodations, but you still gotta, it's good for the patient to learn time management skills and problem solving skills around the barriers that they're experiencing with your assistance. Any questions or thoughts about this? Okay. How many have dealt with this? The patient is always 3 days early for Suboxone and out of medication. Want to raise your hand? They come and they say, Doc, I don't know, I'm just out. I see Steve Lord, I see Langley, I see Leah. It's always the same. And you say, well, let me see, can you bring the pills in? Well, they're gone. So what's happening? What could be happening here? What could be the possibilities why they're running out early?
I've had some clients that are giving it to friends to get them through.
They're what?
Giving it to other people to get them through during their rough days when they're not in the program.
Very good. Okay. And how do you talk to the patient about that? Okay. So I've seen, if you know, and as doctors, we talk about differential diagnosis. So what's the differential of somebody coming in early? First of all, their dose might not be adequate, right? So they might be on 12 or 16 and they're really taking 20 every day. So they're running out early. There could be diversion, like you said, diversion for, you know, altruistic reasons, but still diversion. They could have their medication stolen. I think I've mentioned the program I work in now, 60% of the patients are homeless. When you're on the streets and a lot of people hear your bottles rattling in your bag, they take your bag. That is a real thing. Maybe the person's just not that committed. They're sort of ambivalent. They're taking it, but they're losing it. But some days they take 4 because they're still taking it sort of as a, well, I felt really anxious the other day, so I took an extra Suboxone. And I did that for 4 days, so now I'm out of my Suboxone, right? So how
Lynn,
can,
it
yep,
looks like Lynn might have something to share.
yep. Go ahead, speak up.
The other thing we've been seeing is some people are just trying to say they need 24, they're actually using 16, they're selling some of it, and then they sell extra of it, and then they end up shorting themselves out.
Right. And what do we call that? That's a boundary issue, right? So patients who are, you know, it's nice to be kind to other patients, but they're almost enabling each other. You know, they might be sharing their meds, but maybe be more helpful for them to get them. Glenn, I think you have a pretty empathetic EMS group to say, hey, talk to these guys, or let me take you to the ER so you can get your own meds. But there's a lot of boundary issues in this population. So anybody else want to say something? Please just speak up. Okay, so you talked to the, yep, go ahead. I missed.
I'm so sorry. I think you might have mentioned it already. I might have missed it. Is it possible to have maybe someone who can meet them at their, like if they are having transportation issues or they can't make it out of the house or wherever they are, is it possible that someone can possibly meet them where they are and give them the dose instead of, and not even necessarily leaving them with doses, just being there to ensure that they take their doses?
Sure. You know, a lot of severe mental illness have escalated levels of care called like ACT teams. That there's precedent for that. It's extremely expensive care, and resource heavy. I haven't come across a model that is feasible for everyone, and this happens a lot. What I found more success, we have like a grant for circulation, which is a medical Uber service, and we use that sometimes to get people in, but we still have a limit every year how much we can spend on each patient. So, you know, from a population health standpoint, you can do some of that for the few, and I know in the first week a lot of EMSs will do that, but it's something that can't be for everybody. There's a resource limitation on it. So usually what I do is I start talking to the patient, and you know, I always say this: patients, I trust patients in the beginning that they're able to tell me what's really going on. Over time, if I find that their illness, and I always say this too, hey, if I'm seeing Joe Smith, I say, Joe, you and I are a team against your illness, but the illness resides in you. So I'm gonna, you know, when you're running the show over your illness, then you're in charge. But when your illness is kind of running the show in here, we're gonna set limits around your illness together, okay? So we try to differentiate that. There's a couple things you can do. You can do called a norbuprenorphine test. I don't know if anybody, it's a send out at Quest. So if a patient, I wouldn't do it on the first time this happens, but the second and third time, norbuprenorphine is a metabolite of buprenorphine. So let's say that the patient is just putting a Suboxone tablet in their pee cup when they do their urine with you. It will show positive for Suboxone, but the norbuprenorphine, it has to go through metabolism to be positive. So if you have a repeat offender of this, you could send out to see if they're actually taking it. And the reason that's important is I'm not scared of diversion. It doesn't really freak me out, but I do want to have a real conversation with the patient and say, hey, you've been coming here and you're not really taking this. I'm concerned about you. with my homeless patients, this is really simple. I have some patients who are able to be on 4 weeks, but they get their medication stolen frequently. So we give them a week at a time and they just get refills. So they don't have so much supply. If they do run out, then we're much easier able to work with the pharmacy. If they run out with a week's supply than with 30 days supply. And I also, my patients even stuff Kleenex boxes in my homeless patients in their medication bottles so it doesn't rattle. And I try to encourage them to keep it on under their shirt or on their person and not in a bag that they're sleeping next to. I would also be open with them. Are you overtaking it? If the patient says, yeah, this is very common. I'm having anxiety or I can't sleep, so I take an extra one, because that behavior of I feel I take doesn't just go away because we start Suboxone. So we get them in with psychiatry and we start figuring out how can we better deal with your anxiety. Then if there's somebody who does this every week after week, there is a role for daily dosing clinics. Some people can't handle having a prescription behaviorally. So methadone clinics, a lot of methadone clinics now do daily Suboxone dosing. They can, if you have a publicly funded one especially, you can use that and say, how about we send you there because you're able to get the meds every day and it's hard for you to, for whatever reason, manage it. And then Sublocade is that new medication that will hopefully help with some of this problem, the injectable. All right. Any other thoughts about that? Okay. So let's say this patient is always has an appointment. They're on 1 week, but they always show 10 days after their prescription, and they actually have no withdrawal. You're like, well, how are you so comfortable? They have no withdrawal. With a negative COWS for people who are administrators is the withdrawal scale. They actually don't have any withdrawal symptoms. So it's a little different if they have withdrawal symptoms because they couldn't get here. Obviously, that was probably a psychosocial barrier. But these are the patients that, let's say you had them on 24 milligrams when they first started, and they just continuously come in 10 days after their appointment and they look right as rain. Anybody have that happen? This happens a lot. Yep. So first of all, I always keep these patients on 1 week. But what's going on with the patient? There's 3 possibilities. They're stretching their meds, meaning they may only be taking 12 milligrams a day, but they're getting 24. They could be also taking additional meds off the street from others. Again, we're in a harm reduction clinic, so I'm glad that they're feeling better and they're not overdosing as much, but they're still engaging with drug culture. So, as we get past the acute phase, and for patients who really want to get better, you want to start to address that. And there could be a huge diversion component. This is important to address because them coming to the clinic and having the right doses is important for people. I always want to give people plenty of medication so that they're not sick for 24 hours, but also enough that they only get what they need. It feels to staff like sometimes, I know providers sometimes feel like they're being used. So again, this is another scenario, and I've had patients tell me, well, I want extras in case I can't make it to the clinic. So, and this can happen whether you give patients 30 days, 14 days, whatever your structure is in your clinic. There will always be people who stretch and come in late, who have this issue. So, you say to them again, I'm so glad you came back. It's okay that you're, late. Let's discuss this. But these are the 3 scenarios. You can check that norbuprenorphine level to make sure it's being metabolized. But if it happens repeatedly, usually I give them a warning and I say, hey, if this keeps happening, we're just it might mean that you don't really need this much because I'm not seeing objective signs of withdrawal. So if they do it 2 or 3 times, typically what I do if they were at 24, I'll say, we're going to just drop your dose to 20. And if they come in and they're still doing it, we go to 16. Now, typically at a certain dose, they start coming on time. And when that happens, it's usually the dose that they are actually taking. I also will check a norbuprenorphine level at Quest if I need to. And it's because we want them to kind of stay on a structure. We already talked about failure to launch. You could never address it, but then it's kind of, again, we're not putting expectations on the patient, and it's just whatever everybody wants. And this would be fine if all we did was give everybody the same dose, but if you do an individualized approach to dosing, it's important to address this. Anybody have comments or thoughts about this? Okay. Next scenario, the patient gets Suboxone from the clinic. and they go to other prescribers for controlled substances, mainly Adderall and benzos. Does this happen to other people? Okay. I do want to pull something up. Can you guys see this FDA announcement?
Yes, yes.
Yes.
Okay, so the FDA is encouraging, and you guys can all read this. This is a very good article, because it's very scary. There is an increased mortality with the co-occurring use of benzos and Suboxone. It's not hugely adverse, but the consensus is that it shouldn't stop you from starting Suboxone. And there's a lot of patients who come in, when I see a patient who's just using opiates, it's a rarity. They're typically opiates and stimulants or opiates and downers. And that can include alcohol or benzodiazepines. So this is very much worth reading, but it shouldn't stop the starting of the medication, okay? But it is important to address because the DEA, doctor shopping is not allowed by the DEA. I know in my practice, a lot of pharmacies now won't prescribe if you're going to 2 different doctors for controlled substances. So what we do on intake days, we require, hey, if you've had an open script in the last 3 months for a controlled substance, that we just get a release for that doctor. We ask the patient, we're just going to call them and say, we're going to be taking over controlled prescribing. If they're on stimulants, they have to wait at least 60 to 90 days to have a clearing out, if you will, as well as a psychiatric assessment, so that their lack of focus is not confused with withdrawal. Because when somebody goes through early recovery, there's a huge dopamine dump. It doesn't mean they don't have ADHD, but it means that it's very hard to, everyone looks kind of ADHD for the first period of recovery. So we just say that has to be addressed a little later. In terms of benzos, if the patient won't sign the release, in our clinic, we sort of have a discussion with them about whether they want to be on Suboxone, because that is a big part for us. And you guys have to decide how you want to practice in that way. If the patient starts showing in eForce, because we check eForce every visit, that they're now newly pulling scripts, there's a couple scenarios that typically play out. Sometimes they're not in their drug screen. That's usually because they're selling them. Okay, there's a high price for Xanax, and it's getting higher because more prescribers are limiting giving it in the first place. But let's say I have a patient on 20 milligrams of Suboxone, and they've been doing well for 6 months, but they start pulling a Xanax and script from another doctor. We request the release, and then we keep them on their Suboxone dose. We keep them at phase 1, or we phase them down until they get to phase 1. And then over time, if they continue to pull that script, we'll say, hey, we will help you with the benzo taper. So we'll assist you, but we have to take it on in-house, but you will be tapered off of those benzos. The other thing we offer them is if they say, I don't want to come off of it, I refuse to let it go. What we do is if they're at, let's say 20 milligrams, we decrease them by 2 to 4 milligrams every week while we're doing motivational interviewing along the way. And then we typically call the pharmacy and tell them what we're doing, so the pharmacy doesn't just cut off their Suboxone. Because a lot of pharmacies now will say, you're going to this guy for benzos and this person for Suboxone, we won't give you your prescription. So that's happening at least in South Florida a lot more. So we'll tell the pharmacy, hey, that we're going to taper them every week to try to engage them around this. We'll get them in psychiatric care, have the therapist work with them a bit if anxiety is a problem, and we'll go that route. And we will address ADHD in the future, but we won't diagnose everyone with ADHD. A lot of people with ADHD or who think they have ADHD have comorbid depression and anxiety that's untreated, or sleep problems, or things like that. Not everybody, but some. Questions or thoughts about that? Okay, so let's just get into the benzo alcohol patient who has no history of DTs and no insurance, and there's no public detox beds available, which is the norm in my county. And they're overdosing frequently on opioids. Again, what I showed you from the FDA, you should start them, the indication is that you should at least start them to prevent the overdoses. Because we know, when I think as a doctor, I don't feel comfortable all the time giving them Suboxone, but what I asked myself is, what is going to kill this person? Fentanyl is going to kill them a lot more likely than Suboxone. So on the first visit, I certainly take that approach, but it's not without boundaries, okay? So they have to, so what's the harm reduction approach? We're going to go over, and let's talk about the risks. I know we're starting to run low on time. There is a higher association between, prescribed, oh boy, sorry team, getting a little mouse happy here. This addiction article, there's an association between prescribing benzos, overdose deaths, and buprenorphine discontinuation. You're welcome to read this. And also in the treatment of anxiety disorders outside of substance use disorders, there's a very controversial feeling that benzos should be used in anxiety disorder treatment the way that, in a heavy way. There's small amount, they're supposed to be prescribed in small amounts for short time periods and very much held back with patients with a comorbid substance use disorder. But it's very controversial in general psychiatric practice to be prescribing benzos at all as a long-term maintenance for anxiety disorder. And you have to balance it. So this article in Journal of Substance Use from 2021 was excellent. This is a very common thing patients say. It could potentially be dangerous, but nothing else has seemed to help me. Patient and clinician perspectives. And this is from that article, which very much beautifully talks about the balance. Okay, so there has to be some compromise. And when I first started many years ago, I was absolutely against it, having people on benzos and Suboxone, but I've learned that that's probably not the best harm reduction approach. And I've come to a more moderate approach after reviewing literature and practicing for a long time. So what we do in our clinic is if the patient's willing to sign a release, we convert them to a longer acting benzo. And in the beginning, we'll even see them daily. So I'll do the first visit with them and they'll do a nurse visit for 2 or 3 days where they get 1 day of Suboxone or 2 days, I guess, 2 days of a benzo on a taper. And they come in every day for the nurse to do a CEWA, their withdrawal scale. And the doctor goes into the nurse visit and reviews the numbers as if they're in, I guess, an outpatient detox setting. And if everything looks good, we continue the taper for the benzo and we give them another couple days of Suboxone. So we do this as an alternative if we think it's a very high risk patient to just give them a week of benzos and Suboxone. And that reduces the supply because when you're dealing in outpatient, it's much easier in inpatient because you have control. In outpatient, I send a lot of these patients out to the street. So I have to think if this patient takes all the meds I give them, plus they drink or they take something off the street, am I okay that they're going to be okay? Surprisingly, it's been pretty successful in a large percentage of patients. And if somebody continues to fail at this, then we try to get them into detox. Fail either medically or they just can't, consistently stay on it. But we never stop the Suboxone. We continue the Suboxone. And we only decrease Suboxone if the patient is clinically sedated in the office. But we want them to stop overdosing on fentanyl and use that to maybe engage them around the benzo problem. Questions or comments? Because this is a big issue. And I just want to make a comment. There is a lot of patients too who are on fentanyl and stimulants. And I have a lot of patients who get sober from their fentanyl use, but they're still using a lot of cocaine or meth. And contingency management is a very good approach to that population. There are some patients who tell me straight up, doc, I just don't want to stop. I do a bump of cocaine on Fridays and Saturdays. I like it. I'm going to stay on it. Those patients stay at a week. And sometimes after 2 years, they finally kind of slow it down. We are addressing comorbid psychiatric and medical problems. But contingency management is something we're even looking into, where they get rewards for having clean drug screens. And that is a evidence-based approach that has been especially helpful in stimulant disorders. All right. Any thoughts or questions about that?
Glenn has something.
Yep.
Hey, this is Steven. Something we've run across up here because everything is very territory type. Different areas do a lot of different things. We're running into some stuff we're seeing in Jacksonville now where people are on Suboxone and shooting up carfentanil, which gives them the high, then the Suboxone brings them back down. And they can keep doing this multiple times in a row and they never overdose because the buprenorphine keeps them from overdosing. So I don't know if anybody else has seen that lately.
I think that's a really good point. And over the many, when I started, it was pills and then more heroin, now fentanyl. What I've learned, and now it's going to be something else. Drug use and drug dealers will always be one step ahead of us. And at the end of the day, if they're coming to a clinic to receive the medication, that's a very, very good start. So I would just keep engaging them around that and see how it's working for them. I mean, there is a lot of evidence for those injection clinics. They're very controversial too. There's some in New York, Canada. I know there's one in Miami actually, where people can use their actual drugs in a clinic. There's evidence that over time, those patients eventually engage with the treatment team and start to get better. So I think that I would think about that scenario in a similar way, in the sense that if they're coming to you, it's always an opportunity to engage that patient. And that's where peers are so helpful and motivational interviewing is so helpful. Anybody else? Okay. Let's talk about the unhealthy couple admission. Okay. I'm going to give a case example, and this happens all the time in my clinic. People come as a couple. They come to the ER too. Sometimes both want help. Sometimes one wants help. Sometimes one kind of wants help, but they're in completely different phases or the same phase. And 90%, I mean, more often than not, it's not the healthiest dynamic. So a lot of times these patients, this couple, they've been using together and they're trying to support each other, but they're also very argumentative in the waiting room. They're very disruptive to the peace of the whole ER or the clinic. And they insist on being attached, even though they might be fighting. So what we typically, anyone have this problem in the past? But they insist on being seen together. Okay. So with this one, what we do is if there's a lot of disruption, we go out and talk to each patient alone. And one thing that I do in practice in a substance use program, I want to make this very clear. There's a lot of control dynamics and there's a lot of human trafficking that you're not aware of. They don't look like someone who's being human trafficked. So my policy is I always take a patient back by themselves first before I'll see them with anybody else, even if they've signed a release. Because a lot of times the patient is forced to sign a release in front of the other person. If they don't sign that release, they could go home and get beat up or something could happen. So I bring and I tell the other person, I'm so sorry, I know you want to come back. Eventually you can, but it's my policy that I see everyone alone for at least a short time. So I take the onus in case one of the people in the party is is under domestic violence or human trafficked. And I talk to the patient first before I start anything. Do you want this person here? Because if a lot of times they say, I don't, I'm so glad you did this. I wouldn't have been able to tell you what's really going on. And a lot of times the patient, so what I do is I take the heat for the patient because I don't want them to get upset or beat up at home. And I tell the person, I'm not comfortable having you back here. We're gonna I'm just gonna see this person for now. The other thing is sometimes it's not a domestic violence situation, but the couple's very unhealthy. And a lot of times they have to start, even if they're supporting each other means separating your treatment. So if we have two people admitting together, they see a different doctor, they see a different therapist. Sometimes you don't have the luxury of seeing a different doctor. In our early phases of the clinic, we didn't have that luxury. So I had to see them all, but we always had two therapists. So they always went with different therapists and they always went with different treatment team. And if, let's say it was Johnny and Mary, if Mary said, well, I want to tell you something about Johnny. I said, well, thanks for sharing, but Johnny will be able to tell us about Johnny. And the other thing, so again, we're modeling healthy dynamics because they shouldn't be speaking for each other. They shouldn't be enmeshed like that. And over time, we require them to go to different group-based addiction treatment, so they're not together. And we do a lot of this with actually parents and adult children. I have a lot of parents who call on behalf of their children for their appointments. and we'll say, hey, I'm so glad you're calling. If it happens repeatedly, we'll say, why can, we would like, we'll do exactly that when your son or daughter calls. Well, again, we're trying to help the dynamic grow and them to launch, because some of these dynamics keep people stuck in the same pattern. So splitting them up is very important. And security is important in these clinics. But a lot of times they're motivated to be in treatment by each other. So you do have to address both parties. This is another scenario that is happening in South Florida. I don't know about the rest of the state. The pharmacy's out of buprenorphine and patient can't find pharmacy who has it in stock. This is for insured patients. Our in-house pharmacy typically has it for uninsured. I went to ASAM this past April in Fort Lauderdale, and there was a paper by a University of Miami student group that only 38% of outpatient pharmacies in South Florida have buprenorphine available for patients with OUD. This is a very frustrating problem for my nurses who are constantly, will end an encounter with the patient, we'll send it to a pharmacy, and by the end of the day, we've tried to find 5 pharmacies and this patient can't get help. Is anyone struggling with this in other counties? And I have, yeah, go ahead, Glenn.
On occasions.
Yep. And I have found since the Big Pharma was sued and the Walmart pharmacists were under implication, it's become even tighter. And I get it. Pharmacists are nervous. Some agree with it, some don't. They're just like any other provider. So one thing we started to do was I would have because a lot of times if they understand that you're a treatment program and you're trying to get this patient better, they can't differentiate a lot of times from the pharmacy side what's a pill mill and what's a provider. So I'll call the pharmacies that we prescribe to often, and I'll develop a relationship with them and say, this is what we're doing here. And they start to see that we taper people off benzos and this and that, and they start to trust us. That helps if the reason they don't have the buprenorphine is not that they don't have it, but they don't want to have it because of the liability for them. And so really making a good relationship with your local pharmacies, or picking 3 or 4 that you use, one Walgreens, one CVS, one private, one Publix, so that your patients can get the meds, which is important, but also the pharmacist gets to know you and your practices. Like I said, every county has people who overprescribe everything. So they want to know why you're different and what you're doing different. And a lot of times if you explain it and they can document that, they feel more comfortable. So that's important. You've got to work with your pharmacy teams. And my last scenario is the patient's Suboxone script is putting him or her in danger. I have a specific case for this, but this has come up if you work with a very homeless population. It was a young woman who was a known prostitute in the area. And worked in that manner. She was homeless, but what would happen is a lot of people knew she had Suboxone pills. So because in previous times of using, she had sort of spilled the beans about it. And she was frequently getting basically beat up for her prescription. So she'd leave the clinic, go off site, and there was a group of people that were every time she left, really beating her up. It was putting her in an unsafe situation. And after she expressed to us what was going on, and she had bruises, she was severely beaten, we decided that prescription bottles are not safe for this patient. She had a horrible fentanyl history. She was overdosing frequently, so we did need to do something. So we actually got her into a methadone clinic where she just got the daily dose. And nowadays, if we had it back when this was going on, I would, definitely consider her for Sublocade or an injectable. So I just want to say that not every patient can handle a prescription. I have worked in methadone clinics. Methadone is a fantastic resource for a lot of patients, whether it's because of their pharmacology or they need the daily dosing and structure. And it's definitely should be considered. And a lot of those clinics, again, daily dispense Suboxone. So you also want to discuss ways to help the patient conceal the medication. For this patient, I had a different homeless patient in a similar situation. What we did, she escalated to phase 4. So she was eligible for 4 weeks, but she just got 1 week prescriptions with 3 refills. because she said, if I have too much and it gets stolen, I'm in trouble. A lot of the pharmacies won't give another prescription for it. So we helped with that. So I just wanted to throw that out there, that you also have to look at the situation of the patient, and if having a prescription is actually going to put them in danger. And in that case, you may want to consider an injectable or something else. So that is my last slide. I wanted to thank you all so much and see if there's anybody else with a hot topic that they want to ask about, something I didn't bring up that's happening frequently in their clinic, that they're interested in sort of hearing about. Because like I said at the beginning, these are the kind of things that make staff crazy, make them quit, and make treatment, doing this work very difficult. So is there any questions that I can answer, or the team or the group can answer? Okay. It's been a pleasure, and I hope this was helpful. Please feel free to email me if a hot topic comes up later. If any of you are on this call, it's recorded, so Shannon will be able to share it with you so you can show other teammates if they didn't get to watch it. And I'm happy to give my thoughts on different scenarios if they're coming up in the clinic repeatedly, that's making it difficult for your team to do the job. Thank you.
Thank you, Dr. Phillips.
Thanks, Shannon.
Everybody, have a great one.
Bye-bye.